My name's Natalie Blencowe. I'm a consultant upper GI surgeon and I'm an MRC clinician scientist and a Royal College of Surgeons clinical trials senior lecturer, and that's all based in Bristol. So I've been interested in research ever since I was a medical student. I did a BMed Sci at the University of Nottingham, but that was very much a laboratory-based research post. And since then, I've veered much more towards health services research. So I did an NIHR academic clinical fellowship starting in 2008. And after that, did an NIHR funded PhD. I took 3 years out of my clinical training to do that. And then after that, I did another NIHR post, a clinical lecturer post for 4 years. And that led me on finally at the end to getting my MRC clinician scientist. There are two main areas that I particularly enjoy. The first one is designing better surgical trials, because it's much harder to design a trial looking at surgical procedures or devices than it is to design a trial comparing 2 tablets, for example. And there are lots of methodological challenges, and I really enjoy trying to address those, especially to make sure that the 2 operations that we think we're comparing are actually being done during the trial, so that we can understand and interpret the results correctly and place those into clinical practice. And the other area that I really enjoy is trying to evaluate and study the introduction of innovative procedures and techniques and devices into clinical practice. And this is really important because, of course, we want innovation to happen, but we want it to happen safely. And this is something that historically hasn't always happened. One of the greatest challenges, and it's not so much of a problem now I'm a consultant, is that when you're at the university doing your academic time, the people in the hospital think that you're having a day off or you're on holiday. And that can get quite wearing after a while, because in my opinion, as a clinical academic, you know, rather than doing 50-50 clinical and academia, you're actually doing more like 80% of each one, and you're working really, really hard. So it can be very difficult when your clinical and your academic places of work aren't the same place, if you see what I mean. But that is now much better. It was not so good 12 years ago when I first started this, but things have definitely improved. The opportunity to work with such a diverse group of people in the university, because, you know, being a clinical academic, you're only really one part of the operation, as it were. You need all sorts of different people to design and conduct a large study and get it into clinical practice. It's really fun to do that. And then, of course, it's really gratifying to then see those results come out the other end and then be integrated into clinical practice. That's the absolute goal. One of the best things is that if you are a pure clinician, and I'm told this, I don't know from firsthand experience, but once you've become a consultant, you get quite comfortable with that job after a few years. Sure, there can be little things along the way that are different to what you'd expect, but most of the time it's relatively plain sailing. Whereas if you have another aspect to your career, such as academia, it keeps things really, really fresh and interesting. And certainly in academia, no one day is ever the same as another. And I think it also helps to keep your clinical work really fresh as well, because you don't get ground down by being there every single day. That's one of the best things, I think. There is evidence to suggest that if a hospital is research active, then even if it's not in the area of interest of that particular patient, and even if the patient themselves isn't in a research study, just the fact that they're in that particular hospital can have a benefit in terms of their treatment outcomes. And I think the other thing is that clinicians who are participating in research, especially in randomized trials, are much better at expressing uncertainty. So they're better at saying, I'm not sure. And I think that can be really beneficial in terms of having an open and honest conversation with patients about the best way forward, and not enforcing and imparting your own personal views and trying to just make them go with the treatment that you think's best, because it might not necessarily be best for that patient. But firstly, I think fantastic. It's a great career choice. But I would say, think really carefully about it, because it can take you longer to get to where you want to be. And as long as you're comfortable with that, then I think, absolutely go for it. But that's something that some people don't completely appreciate before they start. And it can be a little bit depressing seeing all the people who maybe were below you in the hospital overtaking you and becoming consultants before you. But once you get your head around that, then it's fine. Some people seem to think that it's an easier option. So certainly in terms of securing a training number, there was a time when people thought that if you went in via academia, then it was easier. And I can absolutely say that that is not the case, because you end up having to work just as hard, if not harder, because you are in two different places. And when you're not in one, you're not visible there. And then you often end up having to work a little bit harder to compensate. So it's definitely not the easier option. In my opinion, it's the more interesting and gratifying option, but certainly not easier. I work with a team of upper GI surgeons, and actually no 1 week is the same as another, because we don't necessarily do the same thing on the same day every week. But typically, I will have 2.5 days of doing my research and 2.5 days of doing my clinical work. So clinical work could be on calls, so taking emergency referrals, taking them to theatre, endoscopy lists, clinics, planned operating lists. And then in terms of research, well, it used to be travelling to meetings, although that doesn't really happen anymore. But there are lots of meetings, whether it be a big meeting or just a small team meeting or a supervisor meeting. I supervise 6 or 7 clinical academic trainees. Yeah, that's about it really. I actually embrace the uncertainty. I think it's what keeps things really interesting. But I think the main thing really is just to be very, very organised, plan ahead, make sure that you keep everything in your diary, just to make sure that there are no more surprises than you already might have. I think that's the main thing, because it can be really easy to get a bit tangled between the two different parts of your career. But if you keep things in order, then that's much less likely to happen. I would have to say Professor Jane Blaisby. So when I started my senior house officer rotation in Bristol, I had never been exposed to health services research before. And I was amazed and just inspired that you could do research alongside a really quite fulfilling surgical career. And that was back in 2005. And I saw that and I thought, yes, okay, that's what I want to do. Firstly, that finishing a PhD can be really, really hard, but it's definitely worth it in the end, especially once you've actually been awarded it. And the second thing is that failure in academia is normal. And I think that's something that people don't talk about enough. There is absolutely no way you could get through a clinical academic career without having failed to get a grant, failed to get a paper accepted. You know, the list goes on, but I think we need to normalise that much more and talk about it more, because it can be so demoralising when it happens.